and I saw that the general guideline and for the review article, actually it is mostly done by invitation. So if we want to submit this article, then we have to send it before submission to the editor and then get permission. So do we
So
need
what?
to consider?
So write the app start. Uninvited review should be no longer than 4,000 words, with no more than. Okay, so after we write it up, we send them the abstract. And just send the email to the editor. That's all we need to. Yeah.
Okay. Okay. And about the title, because this is mostly done about the review, but we have only one case, and it will be it already submitted with the other article. So I think, what about we remove these words in the title? Because this is not our case series. It's mostly already published with, by other physicians. So can we use case series?
Literature review. So why did you use patient inquiry?
Oh, I didn't make this title, but it was already made by someone else. So I would revise it later.
Now, I like double lung transplantation for bilateral lung cancer. A literature review. A literature review. Bilateral lung transplantation. I mean, I like the current and the future, or where we are and where we should go.
Okay.
But it becomes too long, so I'm thinking out loud. The current, the role, the current and future. I mean, the current and future role of, and then you can the same the rest of it.
Okay. And I want to show you the table.
So about the case, we have, like I said, there's an abstract for our Albert Curie case. So we're just gonna cite our own case, and that's it. We're not gonna include any new case there.
Yes.
Yeah. So
But
it's
the
just a literature
case
review.
should be published before my submission.
Yeah, it should be published by the time we publish it. Yeah.
Yes. I want to show another. Sorry. This is the tables what we saw last week, and I reviewed all 5 references, and mostly I could find without asking to the authors, because I could find the initial recurrence site, and it was mostly on the donor side. someone used the transplanted lung or the donor lung. So these were the sites, and the recurrence rate could be found in the reference, but in this article, it is quite an old one, but still this first author is doing a lung transplantation recently. I found it. But he's in the another clinic right now. So these are the empty sites in the article, and if not, others could be found already. So do you want me to fill up these 3 factors with asking to Ahmed?
Yes.
Okay.
So all of them did the BAC here.
Oh, yes, yes.
And then there's just ADC, 1 case
7.
and 2 case.
Yes. Mhm. And this column actually I made because they used some the cardiopulmonary bypass or some not.
No, this is very good because yeah. This is important surgically.
Yes, yes. And we must focus on this total number because in the article, actual number was 969, but among the 69 patients, only 26 patients received the lung transplantation, but others were just a candidate. So the total number was 26. Even 4 patients died because of a complication immediately after lung transplantation. So the one article cited this reference 9 as well, but they counted the total number as 22. So the 4 patients died with the surgical technique because of surgical technique. So do we need to count as 22 as well?
So was it perioperative complication?
Yes, yes. It was not because of lung cancer.
Yeah, then I think you can put 22 and put asterisks and explain 22
Okay.
in the footnote. You can say 4 patient, 26 received, but 4 patient expired due to non-cancer perioperative complication or some. Yeah, just explain, then people would understand.
Okay. Then I will need to go back to my last and I will ask you to Dr. And I just try to understand why it could be so important with concurrent lung transplantation, what our clinic did. So I found several references, and now I'm still studying, but as I know, it could be the contamination. That means not bacteria, but it is cancer contamination. Am I right? And it could be because of aerosol seeding. So in reference 39, actually they saw the DNA comparison between previous cancer and the recurrent cancer, and they found that they had very similar DNA, even if it was occurred in donor lung. So this was the first thing. You can see the original tumor and recurrent tumor shows very similar pattern within all 3 patients. So I think we can use these knowledge in our office.
Hmm. So patient 1, 2, 3. So the observation is the original tumor has recurred in all 3 cases, right? So
Yes.
it's not the immune suppression and then something in the donor lung. It's coming from the original tumor.
Mhm.
So where is it coming from? Because original tumor is out. If let's say if it was out, and if it was in the liver, bone, brain, somewhere else, then it should recur there. But it recurred in the donor. These 3 patients are they recurred in the donor lung, right?
Yes.
Yeah.
As I show you, most of the recurrence were occurred in just in locally in donor lung. It was
Yeah.
so interesting. And some other described the reason would be the cancer would be remained on the upper side of the respiratory tract. So after remove the lung, they had to wash out the cancer sitting cells and then transplanted. Then the cancer was not occurred again.
So I believe in that theory.
Yeah.
Yeah. I mean, there's no other way to explain it. Right.
Yeah. I was curious of why it is only locally recurred, but this was the theory.
Yeah. So
So
sometimes they do trachea transplant, trachea. So so if you cut here and here,
mhm,
then what about the Y, whole trachea? If there's a
mhm,
seeding there, then it will spread to the a transplanted lung. So like you said, do the washing
mhm,
or just get the very high up tracheal level. Just transplant the whole lung all together at the same time.
mhm.
I don't know if they describe that, whether lung or they do very high up sleeve. Do they mention?
No, no
No.
one described such a detailed certificate.
Mm.
So can we emphasize in our article
Mhm.
with the concurrent lung transplantation?
Mm.
We have only one case, but it was concurrent one.
So did any article you read and
No, no,
say anything about that?
no. I just looked for thousands of times, but no, I couldn't find it. So it should be very special factor, you know.
Yeah. I asked our surgeon
Mhm.
before. He wasn't enthusiastic about it, but I think we can I think we can write it that way and have him revise as he wants.
Okay,
Concurrent. So what about non-sequential?
non-sequential.
Yeah, non-sequential. Because concurrent lung means it feels like you're doing lung transplant and something else together. It's not, it's
Uh-huh.
so it's not like you do the right side and the left side. It's
Uh-huh.
like doing putting all things at the same time.
Okay.
Yeah, non-sequential is better. Yeah.
Okay. And this could be 22 IF. And we move on the other project.
Mm. No, before we do that, Liam,
Uh-huh.
did Liam tell you what additional information I wanted? Liam, remember we went through this project? Did you tell her?
I'm I'm not exactly following which part of the discussion we're referring to.
The whole thing, I mean, you showed me the NEJM paper. Remember, Liam?
Oh, for the double lung transplant review.
Yeah.
Yeah. I discussed that with Dr. Chian and Dr. Chisa.
Okay. Good. I just want to make sure. So asking the original authors for more information is the key of this paper. They may, I mean, if they still say we don't have it, or they don't respond back to you, at least email them a couple times. And if they don't respond to you, then you just you just say in the method, was not able to obtain for this article or something.
Actually, these factors for that you talk to the Liam, and actually I could found most of the research in the reference. I'm ready, and only these are the reference 35.
Oh, okay.
I think
I
I
see.
have to ask it to Ahmed, but others I could find, even if it was not written in the table, but it was in the context.
Okay. For the recurrence, you need a timeline, by within what 5 years or one. Every article is a little bit different, so.
So timeline after transplantation.
Yeah, after transplant, this recurred, 2-year recurrence, 5-year recurrence. So the recurrence, is that 5 years? Because look, the survival is 5 years.
Yes.
So I guess the recurrence is 5-year recurrence too. Let's go back and yeah.
To be a 5-year recurrence, because within 2 years, most of the cases recur.
So yeah. So disease. So what I'm asking is disease-free period. A lot of it would give you range and the mean. But what I want you to do is ask them individual, so that you can do a pooled swimmer's plot, like
all right,
individual. Then you can make a graph and you can pull that, you can have the median for everybody altogether.
Okay.
And then you can, I mean, there's for those individual. So here there's a single transplant.
Yes.
So explain why they did single. Because there's a lot of pneumonectomies done, but they don't do transplant. So was it that they took out 2 lungs and they were only able to put donor 1 transplant?
No, it was just a single lung was removed and the single lung was transplanted. They included those cases in the buffer.
So why would they do that?
Because the cancers were not all bilateral.
So then so I'm thinking that's not the focus of our review, because we're reviewing the bilateral lung cancers only.
So do you want to put in the only bilateral cases?
Yes, because that makes sense. Because well, I guess my only guess is that if you take out 1 lung, the lung reserve is not enough for patient to survive because of bad COPD or something. Then you make sense to transplant even single lung.
then I need to ask all of the authors about the only bilateral case.
Right.
Oh,
But single with heart, bilateral with
yeah.
heart. I guess with heart is fine, but single.
Mhm.
Single is
Not our fault.
not our focus, really. Yeah, we're not really advocate. I mean, Liam, did we specify bilateral? I mean, because we're our protocol is double, right?
Yes, it's a double lung transplant.
So I mean, if we cannot tease out bilateral, then we can't just say we can't. But I think we should just ask authors, we're reviewing just the bilateral cases, so are you able to give us, the individual,
Mhm.
Use of recurrence, recurrent site for individual, not like as an, yeah. And disease-free survival for individual. And then just say we want to credit you as co-authors because you're giving us new information.
Mhm.
Um,
Oh.
yeah. So that's a good point. And then for the individual cases, it's also good to give us histology, PAC or ADC.
Okay, yes.
So maybe it's best to give them like Excel file,
Yes, I thought.
yeah,
Yes,
so that they
I
can
will.
put it for us. Yeah.
Definitely. Yes, I think it's that.
Okay, now we can move on.
Okay. I'll move on to ctDNA project. And actually, the all samples are prepared in Korea, and they're still in the freezer. And the patient's total number was 34, and the samples were 190 samples with a 356 vials. Because this tube is a small one, 1.8 milliliter, so
Mm.
it should be divided. Actually, we use this plasma for several other projects, so that's why we divided. And now I get all of that. So my my team already prepared all the patients.
Okay.
Buckets. So I think I can make a presentation tomorrow. With one. And if the company is confirmed and the NPA is prepared, then I can just submit the IRB. So these are the all serial samples. Diagnosis during neoadjuvant chemotherapy, after neoadjuvant chemotherapy, which means before surgery and after surgery. At least 3 and mostly 4 files for time point.
Okay. Did you make slide or for the company name?
Oh, yes, I'm still making, but before I'm making, I just want to put several other things. So I want simple presentation, and I need to fill up the table, and I think I can done it today.
Hmm. Oh, what is ABCD again? Oh, the time points.
Yes, yes.
Oh, okay.
Yeah.
Mm,
It should be revised again.
So total 32 patients,
No, 34.
34.
Yeah.
And then what about number of samples?
I didn't put it here, but it was at 119 samples.
Oh, okay. So after surgery, do you have any more follow-ups?
Actually, no, because we had already too many samples, and we were exhausted collecting the samples at that point.
Mm,
And I just found the types of the sample, but I was so disappointed because it was most of were useless. It was only one time point, and it was not severe, and even the plasma volume was so so less to make a research. So right now they are collecting again um, with the metastatic HER2-positive breast cancer as a perspective, but at this moment we just stop. Yeah.
mm. So I think you should have your research people for these 34 patients work on, event-free survival and overall survival.
Oh yes. Yes. I can show you.
And stage.
Mhm. Um, one of my fellow collected the data. So this is clinical stage, and these are the before surgery immunohistochemical stain was done, and most are HER2 positive, but one case, as I remember, it was before HER2 negative, but after surgery it was confirmed. And you can see many cases shows PCR.
Hmm.
Type was all IBC.
IDC. Mhm.
IBC is invasive ductal carcinoma.
Wow, there's a lot of PCR.
Yes, HER2 trends are really they have.
So this is PCR of the breast mass.
Yes,
What about lymph node
and
PCR?
here in
Hmm.
this case, actually breast PCR, but lymph nodes is not, and the breast was not PCR, even the lymph node was not. But most case shows breast and lymph nodes both PCR.
Hmm.
So that's because the PCR rate is really high in HER2 positive and triple negative breast cancer. So that's why we use immunotherapy
Hmm.
if it is only stage 2.
Hmm. Hmm. Hmm.
Regimen was mostly done by pertuzumab, uh, Herceptin, and taxocarb.
Okay. Very good.
And half of the patients will receive the endocrine treatment.
Mm.
They show the or
No one recurred.
yeah, but one metastasis. Yeah, it is good for me, but not good for research. Actually, I should be happy.
Mm,
Oh my God. And Louis Pirate.
mm, mm,
Yes. They found fluorescence only 2 or 3 years,
mm.
so we need to see with a longer follow. Later, maybe we can get some blood samples from these listed patients, and we can compare the ctDNA after 1 or 2 years later.
Mm,
5 year longer follow-up ctDNA.
mm, mm, mm. Yeah, one recurrence is, I just wish we have few more. But this is what you checked most recently, the recurrence.
Yes, last week.
Okay. And then is this all neoadjuvant or adjuvant too?
Yes, all neoadjuvant.
Okay. What
Yeah.
about adjuvant? Do you have any adjuvant?
Adjuvant patient, the quality of samples were not good, so I just selected that.
Oh, you mean not enough sample?
Someone had less amount of samples, and someone was just had 1 or 2 time points, which was not enough to get the research.
Oh, okay. So we're
One
just
is-
going to do neoadjuvant.
right now.
So for neoadjuvant, the good thing is we can correlate with PCR.
Yes.
You know.
Mhm.
With that we can correlate. I think just one recurrence, I don't think we'll have any meaningful correlation. We can still look.
Mhm. Actually, I thought that a homogeneous population would be better to get some meaningful research. So
Yeah.
let's remove the HVAC.
Mm. Yeah, I think HER2, we have such a good drug that not many of them are recurring.
Yes, mostly within 2 years, if there is no recurrence, then the recurrence rate drops off. So these patients are very good candidates for the target therapy. So I think pertuzumab is really, really good drug. Before that, actually, I experienced 10 or 20% of a recur
Oh,
cases. But right now, I don't have recurrent case. I don't have a locally recurrent case means that I don't need the surgery again. Whatever it could be distant method, if the oncologist will treat them, surgery no more. So I'm so
oh.
happy.
So this one patient, where was the recurrence? Lung?
Yes, multiple lung metastasis.
Oh. And this patient had PCR? No, oh no. T2, still T2.
Oh yes. So,
Hmm. Stage
yes,
3,
still
but no 3 sentinel lymph node. Okay. Hmm. Well, I think it's still, I think at best, we're gonna show nice reduction in ctDNA.
Mhm.
We can look at correlation with PCR.
Mhm.
So I just, think about, maybe be critical. I still think we could do this research, but if we are in a limited resource country and the ctDNA is still expensive,
Mhm.
can you argue why you need this test? Because pertuzumab is such a good drug and most people don't recur and a lot of them get PCR. You still need help of ctDNA in this setting, in this population.
Well, in our population, actually, there was no recurrence case, but most in the HER2, all of the population, still there are very high burden tumor cases. So we need to um, select, we need to distinguish whether the patients will have less burden or high burden and a high rate of recurrence possibility. So this ctDNA could be made as a very like commercial, which is not expensive chip or kit to be made. It would be so helpful those population, even for the the country is not rich. So that's why right now the research is important.
So are you saying not this population, but with higher or more like adjuvant case or metastatic case we need it, or?
Actually, HER2-positive breast cancer shows um, many patients shows a recur or distant metastasis, but not our population, but they are still. So compared to the hormone-positive breast cancer. So if we use ctDNA and with many researches, if this ctDNA detection method could be made as a commercial one, which is not expensive, then it could be helpful to those patients.
But in what setting? Like when do you want to use it the most?
Uh, at the diagnosis,
Diagnosis
mhm, and
after chemo?
after treatment, yes. Then in the later future, but maybe we can skip omit the surgery and adjuvant treatment. You know, the surgeons are doing their research to omit the surgery right now, even in Seoul National University. You know, when she comes, he's not, right now he has a clinical trial to skip the surgery.
Using ctDNA, skip the surgery?
Actually, it was not ctDNA, but NGS, but they are skip the surgery. Yes,
NGS to skip the surgery?
yes. After chemotherapy, they do the NGS, and then the differences between before treatment and after treatment, and they decide whether the patients will receive surgery or not, and adjuvant treatment or not.
In what stage?
What stage? Um, early stage. I mean less than stage 2, I think.
Less than
Stage 2,
stage 2?
yes. And even in Samsung, they are doing their clinical trial to skip the surgery in external lymph node. So if they are combined, then the surgery will be disappeared for the breast cancer.
Hmm. But where are they doing NGS from? Blood?
They have their own company. They made. I mean, Wenshikan made a company.
I didn't hear you. NGS from what tissue?
Breast tissue.
So after chemo, they do another biopsy and do
Yes.
NGS?
Okay. Mm-hmm.
Hmm.
Because they think needle biopsy is less invasive to the patient than the surgery. The needle biopsy doesn't remain any pain or incision, and it could be done very quickly. So they want to replace the surgery with the needle biopsy. Or
So-
sometimes a vacuum assisted biopsy.
So needle biopsy can confirm PCR?
Yes, they think if the tissue could be obtained 3 or 4 cores, which was obtained in the whole best, not only one point, but scattered pattern we can obtain the tissue, then these tissues can represent the main tumor. So if the PCR was confirmed in those little biopsy tissues, then it could be really PCR. So they're doing clinical trial. They're comparing the both of the
Interesting.
yes, the surgeon will be disappeared in the near future for the breast cancer.
Hmm.
And still, actually, breast cancer is considered as a systemic disease and not local disease.
Hmm.
So it might be possible. The reason the surgeons try to those kind of omission of surgery clinical trial is we just want to avoid very difficult case which are very high burden and was the lymph nodes are stuck under vessels and we can't remove it. So if we have other options, we can make smaller. We can do just a simple surgery for those patients.
What about radiation?
Radiation for breast cancer remains so many sequelae. I mean, not the skin burn, but it remains lung fibrosis because they have very good technique right now, but still patients suffer from the pneumonitis and even the um, lung fibrosis and rib fracture is very commonly up. When they just cough, then they got the rib fracture after radiation.
Hmm.
So in bone scan, it just looks like a metastatic lesion on the rib, but it was just a rib fracture. So it's so often common. So if we can avoid the radiation or the invasive surgery, could be good for the patient.
Hmm. So maybe if we find out, I guess, CPR in both breast and nodal,
Mhm.
every time it happens, it clears ctDNA post-op, and there's no recurrence, then this would be another good population to avoid surgery.
Yes, but before surgery, we have to find out those population. So that's why we need.
Because it's hard to show nodal CR Because you're gonna have to biopsy all the lymph nodes.
Well, actually, if there are 3 or 4 metastatic lymph nodes before treatment and after treatment, most lymph nodes are reserved, but only one is remained. It could be the central lymph node. Mostly the central lymph nodes is finally remain, even if the other lymph nodes were just cancer cell was gone. So, with ultrasound, actually, it is a quite good method in correlation to the PCR, and we can predict the PCR only with the ultrasound. There are many clinical trials to omit central lymph node with only surveillance with ultrasound. These clinical trials are done by radiology.
Interesting.
Yes, ongoing clinical trials. We're still waiting the result,
Mhm.
but as I know, it showed a positive result. I mean, we can skip central lymph node for early breast cancer.
So I'm thinking, if we do this research, how would this change our practice? So we have to think about that question.
Mhm.
So if we see good correlation, there's ctDNA after chemo, it's gone. And
Mhm.
after surgery, it remains gone. Where there's group that there's a ctDNA with chemo, it's not gone, but it's lower. After surgery, it's gone. But with chemo, let's say mass and nodal PCR, is it always gone? Is it, or is something remain? So we can kind of look at how tight is that correlation? And it could be, is it a marker of prediction of PCR? And PCR, we know it's a good predictor of recurrence. So I think, we can use this as an additional way to ensure, yes, there's a PCR. Of course, you have to do needle biopsy, but if it can save you from surgery if the ctDNA is gone, and if needle biopsy is PCR, then let's not do the surgery, even in HER2. Maybe this is a way to ensure that path is right.
Mhm.
Do you agree?
Yeah, I agree.
Okay. So next step is when you go back to Korea, you do that, but it's taking, well, you need work. Needle biopsy, but you guys do the needle biopsy, right?
I do by myself.
Yeah. So you
Yeah.
still work.
Yeah, because radiologists, they don't want to make additional work for
Hmm.
my research, so I do everything by myself.
So if we see nice correlation, then your next step is, for those patient with PCR and disappearance of ctDNA then you actually you do that and show that no one recurred.
Mhm.
That's, yeah, I think that could be practice changing. Yes.
Yes.
And I
Good.
think the future is, this regimen is really good, but also, what about the triple negative? Do you have atezolizumab approved in Korea?
No,
Oh, okay.
yeah. Still, only chemotherapy is available for treatment with breast cancer.
But in United States, we use atezolizumab
Mhm.
in triple negative neoadjuvant.
Mm. Mhm.
You know the data, right?
Yes, I know the data, but we don't use it. It's so expensive.
Yeah. So that I think if that would be the next step, triple negative. Let's see the correlation. ctDNA and neoadjuvant in triple negative. But it's gonna be hard to do that in Korea because in Korea you're not using the US regimen, so
Yes, yes.
it's tough. Even if you show anything, like US will say, "Oh, that's not the regimen." Yeah,
I can publish a US journal,
yeah,
maybe the European journal or Asian journal.
yeah. Okay, okay, okay. So let's present this at our when is our meeting with Pridison?
So we have two meetings. We have to reschedule both of them because of your schedule.
Uh-huh.
So we don't know when it could be. Leslie is going to see one of the recent emails from Predison. So because Shidong is in China, they were asking if we can do an earlier meeting, potentially like in the AM time, either Tuesday or Wednesday.
AM,
Yeah.
Tuesday or Wednesday AM. So
It'll probably, like, the best time that will work for them will be like a lab meeting time-ish, because it's gonna be around, so if it's like 10 AM here, I think it'll be around like midnight over there.
yeah. So what about if we do? Yeah, we can do 8 to 8:30 and start the lab meeting at 8:30.
Okay.
Let's
Well,
propose that. I mean, we can even do one meeting 8 to 8:30, the other meeting 8:30 to 9, and we can start the lab meeting at 9. That's also possible.
okay.
Yeah, you can propose that for next few Tuesdays, because that's the time limiting thing. We need to make this happen.
Mhm.
And even for Wednesday, the Wednesday I have two more boards, so that's 7:30 to 9. So Wednesday we can propose 7 to 7:30 if they want to do Wednesday. Yeah, and let me know.
Okay.
Okay, Jion, anything else? You're muted.
I have another project with Arnie and Eugene,
Yeah,
which is I have a progression, but unfortunately they can't come today. So I will show you the brief research what we did. So the patient's characteristics were all filled up, and for this table, Dr. Jack, can you see the table 2? Actually, this is about the population who progressed and partial response and stable disease. We think it is not so important in this article. So if you agree, we will make it as a supplement.
I'm trying to understand what it means. So if you do only target lesion as the original definition, you have 26 patients that are progressed. malignancies, but if you
Mhm.
detect, add new lesions, it's 36 patients,
Mhm.
and then total regimen number of combination therapy.
Yes. This is based on the number of a patient,
Mhm.
and this is based on the total number of a regimen.
Mm,
So it is quite confused, right?
I see. I see. Hmm. So I'm just becoming wearing the hat of the reviewer, because we said when we add the total number, it didn't correlate well with PFS or OS.
Mhm.
So the answer is, um, let's only do the number of patient. Let's take out the total regimen number, because it's gonna confuse the reviewer.
Okay. Mhm.
And then if we add all detected new lesions,
Mhm.
this is what happens. We can put that in the supplemental table.
I will refine.
And
will refine.
yeah,
Mhm.
yeah, go on.
Okay, this is the table 3, and it is also based on the patient's number and number of a regimen. So we need to take up this column.
So again, when you say total regimen number, it doesn't make sense.
Mhm.
I would say, so in the method, you have to explain it well, what it means. Like
Oh, okay.
each, when we use only patient number, we're only counting the the earliest line of therapy, or line of therapy is better. So because number of patient, so what does that mean? It means you're only counting when, so this is how I would describe. When patient had multiple lines of immunotherapy containing regimen, the first method, okay, you could say first method, second method, or
Oh.
because it's really not the number of the regimen or number of patients. So the first method, we're only analyzing the earliest immunotherapy used regimen
Okay.
for that patient's for that case analysis. So because you're just doing one regimen, well,
Mhm.
I don't want to even use a regimen means like recipe. Regimen means like, is it chemo or combination? But we're not, that's not what we are focusing on. We're focusing on line of therapy. So if we're using only the first earliest immunotherapy containing regimen,
Mhm.
that's the first method. And the second method is if we count all the immunotherapy containing regimen as a separate case, we will then we're analyzing all different lines of therapy as different cases. So that will be the second case. So I think you have to word it right, and then just call it first method of counting cases, or case number per first method. And then you can say case number per second method, or something
Oh,
like that.
okay. Okay.
It's a case number, but you're counting only one regimen for one line of therapy for one
Mhm.
patient versus you're
Mhm.
counting multiple lines of therapy as different cases in one patient.
Oh,
I
okay.
think people, we have to make sure people are not confused by how we count cases.
Mhm.
So explain that really well in the method section, and then afterwards you have definition, case per first method, case for second method. And you should,
Okay.
now we've decided to do this way, for the other supplemental table. Let's just do it both ways. I said erase it just because I thought it was confusing to call it that way, but now we have a, if we call it with the new definition, the clear definition, I think it's fine to do. Yeah, both. Okay, good question.
And um, we just did the univariate analysis using as the result, so I couldn't get. And sorry. And this is. Can you see my screen right now? These are the 9 cases based on the Champia, the definition of Champia, and we checked one by one. And those are the organs and freebase based post treatment, and this was the follow-up safety research. The not applicable case because of a patient disease. And so we just wanted to figure out whether the hyperproportion is real or not. But all 9 cases were real, true hyperprogression, as we think.
Is it except for, what about NAs?
Actually, yesterday, Eugene, Arnie, I discussed about this question. But if the patient already died because of the lung cancer, it definitely could be the hyperprogression. How
So
do you
both
think?
patient died, 9 and
We
what's
find actually we find from 9 patients, I think we find 4 is disease. So it means like
Yes.
it's rapidly hyperprogressions. We can say that.
so who died? Number 9?
Number 9 and number 4 and number 3.
So 3 patient died
Mhm.
before the next scan.
Yes,
Hmm.
because of the hyperprogression, I think. Within 1 or 2 months, they died.
So write that in the discussion, even though we don't have the confirmation scan post-treatment. And make sure patient didn't die of something else, like something else. But if and all patient died from disease progression, what else could it be? But just make sure it's not really like something else. Then we can argue these patients most likely are true hyperprogressors. Yeah. Okay, so at least from our data, we could argue there was no pseudo
Oh,
hyperprogression,
we don't.
right? No, I think it's good to show that. Good. Okay. Anything else?
Arnie, do you have anything else about our project?
Mm, I think you already like showing all about all the things that we want to show to Dr. Che and also the table. I think if Dr. Che already accept that, then we can make something next week for the paragraph. I think because we already checked the Champion one. We can say that.
Okay, so are we writing it up
uh, Arnie?
Yeah. We will. Yeah, we start writing it up actually, but last time, because we agreed that we doesn't want to make a new definition, so that's why we kind of revise all the table again, and also try to find the other patients. Gian, actually, did you already discuss to Dr. Che about the two patients that get lobectomy?
Oh, actually, I reviewed 2 cases, and it was not the surgery at that moment. The surgery was done before treatment.
Oh, okay,
So
then it's okay then.
yes, we don't need to.
Okay, then it will be fine then, because we already have a quite good table. Then I think we can try to start writing it. Thank you, Dr. Che.
No problem. Okay, good,
Or I have to. Thank you.
good, thank you. Dean, do you have any updates?
Hi, Dr. Chang. So for the BMC cancer case report, the editor actually got back to me and said that they are no longer accepting case reports. So we
Hmm.
wanted to ask which journal you would recommend. The person who I was in contact with, the editor, they said they would suggest Journal of Medical Case Reports, but that one didn't sound very familiar. But wasn't sure if there was other ones that you wanted us to submit to.
What was the title of this paper?
It was differentiation syndrome in a patient with non-small cell lung cancer harboring IDH2 mutation treated with venicitinib.
Try JTOCRR.
JTOCR. Okay.
They're very short. You might have to lessen the content.
Yeah. Okay. Okay. And then if that one, or that one definitely accepts case reports, but should we have like a backup journal as well in case, or should we just see how that one goes first?
Back up. Case reports. So BMC, they recommended.
Yeah, so on the submission portal, they said, oh, this is not within scope, but here are a couple other options.
Uh-huh.
And so they listed out a couple different ones. But then the person I was in contact with on the editorial office, he recommended this Journal of Medical Case Reports.
It's a BMC journal.
I'm not so sure about that.
Yes, it is. Journal of Medical Case Report.
Oh, okay. Yeah, so I guess
Dion, do you
that's
know
cool.
this journal?
This journal is impact factor is 1.07,
Hmm.
and it is not SCI.
It's not SCI.
I don't think so. No, I don't.
But I guess either way, I can do the submission for JTO CRR first, and then see how that goes. Because we have all the material already. It's just a new platform.
Yeah, I just wish we had lung cancer specific. So there's a journal called Lung Cancer. I don't know if they accept case report. Case reports in oncology. Yeah, I'm having a hard time with case reports.
Okay, so I'm looking for the lung cancer journal. It says they rarely publish case reports, but
Is
will
it-
consider unique cases. Yeah.
Okay.
So I can do JTO CRR.
Yeah, and then you can put PMC medical.
The one they recommended.
Yeah, you can put that as a
Okay.
backup.
Okay.
Okay, let's do that.
Okay. And then for Dr. Pedro's
Yeah.
stuff, I'm going into lab later today to finish up the stuff that he had asked for the patient charts. And then I think next week I can present kind of the most up-to-date manuscripts for his, and then also Dr. Elena's for feedback. And then I think, yeah, kind of.
Yeah, those two are the most important. We have
Yeah,
to finish it, so I rely on you to follow up and finish.
yeah.
Yeah, next meeting you can ask me questions. Yes.
Yeah, I can present those.
Okay, very good.
Thank you.
You're welcome. Okay, Jisang, do you have any updates on what you're doing?
Actually, not really today. So so regarding radio mix, the segmentation is still on process with Cecilia and team.
Mhm.
So I think it will take some time to finish. So so we have more than 200
Mhm.
patients to go, but actually, yeah, it'll take. I think it takes more than 30 minutes on average to finish one segmentation. So yeah, but I will follow up with Cecilia and teams. And I'm still looking at the original articles from the reference I shared the last lab meeting. But it's not finished yet, so I will share if I'm done. And also, I gathered all original article about double lung transplantation with Dr. Jian. So, and I also looked up some articles.
Mhm.
Right. Yeah, that's all.
Okay. Okay, very good. Liam, updates?
Oh, hi. Sorry, I couldn't find the screen for a moment. Yeah, so updates. So not too much for me this week as well. In terms of like content to go over. So for the protocols, the biomarker protocol, again, is all approved. We're just working on the contracting and the budgeting. So I have a question regarding the budget that I'll go over with you later. The double lung transplant protocol has been submitted to IRB, so it's pending their approval. Once they approve it, I think we should be ready to go and up and running. With regards to pacemakers, so we're making good progress with pacemakers. So we just did Marky's interview yesterday. So Tim is working on that. So we should be able to release that video in the next couple of weeks. He's also working on Dr. Sierra King's video. So we're doing the best we can with the audio and the video quality that we have. So that should be the next one that's available. CC is also working on Dr. Chin Young's pacemaker interview. So that should be also coming up in a couple of weeks. And then our next interview that's coming up is going to be with Dr. William Bay. And then probably after that, we'll have to interview Pedro and Sarah.
Okay.
And CC has been doing a good job with like updating our website as well as our Instagram account. So she'll continue to be in charge of the Instagram account, and Eileen and I have been working on updating the website so that we can accept the members' like email addresses so we can reach out to them. And we're going to also send out reminders to the current members to submit more stories. Yeah, and then regarding the manuscript, I've been working with Sally, Eileen, and Grace. We've been meeting on a weekly basis. We are currently working on our first draft. We have another meeting coming up later this week. So I think we should be able to have a first draft ready for you to see in a couple of weeks as well.
Okay.
And then we just have a bunch of meetings coming up, but then some of them we had to reschedule because of your timing conflicts. So I'll relay that information to Predison for 8 to 9 a.m. on Tuesday and 7 to 7:30 a.m. on Wednesdays. Yeah, and then we have a couple of meetings today. I think we have one at 2:30 with Bertus. We have Natera.
So why are we still rescheduling? Because I told you I can't do after 4.
Mhm.
You know, it should be rescheduled right after then.
Yeah, so we sent out an email. I'm not so.
They didn't respond.
Yeah, basically. So some of them. Who is this? Leslie wasn't up to date on your schedule change, so we had emailed her on Friday. So she's just got up to date now. And then the other places haven't responded back yet. So the other meeting we had to reschedule for today was OncoSite with Dr. Huiping Liu. That was scheduled for 4. But yeah, that's something we're rescheduling again. Yeah, and then so if you have time now, I can ask you the question regarding the budget for the biomarker. So I emailed Dr. Huiping Liu with the questions that we were having. So you know how the budget right now has it so that the Path Core collects the samples, they process it, and then they send it to the CTC lab. So our question to Dr. Huiping Liu was, can they collect the samples directly so we can skip the Path Core? Her response was, unfortunately, they don't collect the samples directly. So we do have to get the PathCore lab involved.
Okay,
Um,
the
and then-
PathCore to collect. What about processing by call?
Yeah, so that's the part I wanted to ask you about. Let me just quickly share my screen here. So this is Dr. Huiping Liu's response to that email.
Specific protocol analysis starting from distinct tube collection, so the processing is different. If the storage fee is beyond the current budget, we may charge the patient for now, and the rest can be charged later when samples are requested. Distinct tube collections requires specific protocol and analysis.
So I think the storage fee, I think we can just put down 50 per patient and then move on with that, right? I
Yeah,
don't know. I don't know how much like extra they want to charge later, but
I don't know what she means by distinct tube collection.
so I wonder if that's like the Streck tubes and things like that.
Now, Streck is used for that's expensive, and we're not doing that. We are unless the company provides it to us.
Mhm.
If they want to provide it, yes, they can.
Okay.
So the rule is that space if we need special tube, the
Mhm.
company has to provide it. No, that's
Right.
number.
Mhm.
Company should give us how to process. You know, what do they want with the sample? So
Right.
based on that protocol, we will process the sample, like by call and plasma in what tube. So it's vital that we have that, you know, in our like a manual, and then we send it to either CTC or PathCore to process it.
Yeah. So basically, my question is like, do we need does PathCore need to process it once and then CTC have to process it again? Because both PathCore and CTC has different price tags for the level of processing. So the PathCore, the blood collection is like the basic is $114, but then if you need the advanced to like the FICO stuff, I think that was like $202. And then if we come over to the CTC side, the processing fee for a basic was $68, and then for the complex was $86. And Dr. Huiping Liu was suggesting that, or was telling us that we have to go to the complex price. So I'm wondering if we have to do do complex for both. So it'll be $202 for the PathCore processing fee and then $86 for the CTC processing fee.
Yeah, I don't think it makes sense to double charge. I think so. At this time, I'm doubting whether we need to work with Huiping to have it stored there. If we can just use PathCore and store there,
Mhm.
maybe we don't have to go through her.
That might be an easier option. and I assume the path course should have the capacity to accommodate for the individual lab manuals that's provided by the companies, right?
Yeah. So let's do this. Before we tell Whipping we're not gonna use CTC,
Mhm.
how about we, because this is a shared effort, like, yes, she could charge anything she want, but also it's for her, she has access to the samples. And it's not like we didn't add her lab into our protocol yet. We're not giving, you know, in the lab, in the protocol, it's not like we're giving her certain cc's of sample. If you have our previous 100 patient protocol, there it says, you know, the sample will go to Dr. Whipping Wu's lab. Remember?
Mhm.
So it's for mutual benefit that she wasn't charging us for any processing or any storage because she's getting sample for free.
Mhm.
Other companies are paying a lot of money to get the sample.
Mhm.
Do you understand?
Yeah.
So it's a mutual win-win situation. But then this time it looks like she's charging everything.
Mhm.
So I don't have advantage of working with her. I would rather,
Right.
and then it becomes harder to work together if, like, I need sample and she's like, well, I need to make sure it's a good company, you know, I have the sample. It feels like, you know, because sample with her, I don't have the liberty to get all the samples out.
Right.
You understand?
Yeah.
And I didn't pay for her. I thought giving her sample was enough.
Mm.
So it here, this with the new protocol set up, if I use CTC, I think because she's in charge of CTC, she's gonna charge everything. And then you know, in the end, I don't know if she'll get good paper out of these samples, you know, and then she's gonna be similar to what she's doing right now. Like, you know, like we need to get good, you know, something out, but working with different companies. Now, so my suggestion is this. So why don't you actually go and visit PathCore, meet with the PathCore director or the PathCore people who does actual collection, and go and see where where they store and how they process, and like the lab manuals,
Mhm.
like example lab manuals, and like you know, what do you actually guys do, and do you have, where's the storage place, and you know, like we need to have a, you know, nice point of contact, like put a name to face, and or face to the name, and just say, you know, and then you need that person's cell phone number, something like, oh, I have the samples, can you come and grab it, or, you know, like, can you come and store it. You just need to work very closely
Mhm.
with someone in the PathCore. First job is to know who they are, know what they're capable of, and this is probably amount of sample we're gonna collect. And sample collection, like, if I call, do you guys, you know, what is the process? Before, one of my fellow, he brought the kit to the phlebotomy site,
Mhm.
and when it's done, he picked it up and give it back to the PathCore.
Mhm.
And PathCore runs it on that day and process it and stores it.
Mhm.
But the fellow had to get out of the clinic, get the sample kit to the phlebotomist in clinic, and when it's done, after, you know, like, it's like deliver. It's like you do that. You check who's coming before, and tell the PathCore to prepare for analysis the next day or something.
Mhm.
So I think you have to talk to PathCore and see what, and then if we're paying for collection, can they actually come to the phlebotomy site and collect it themselves, not you, Leo. So
Yeah.
I feel
Yeah.
like, what are we paying for here when we say collection?
Mhm.
And then when we say processing fee, are you able to, not your own manual, like every company has different manuals, so are you able to accommodate and allocate them in a way they want and store in a day, in a day with, and do you actually have a storage place? And last protocol, we didn't get any charge for storage because Ping Lu was storing it in her lab.
Right.
Now it looks like she doesn't want to do it anymore.
Uh-huh.
And use CTC, but that's all not, it's another core facility where we have to pay for everything. Core means you pay for everything. So if we're paying it, that we don't need to use Clipping, I feel like, and then, so if PathCore has facility enough for me to pay for storage, and there's no set price sometimes. I mean, there's set price, but if we can negotiate, this is an investigator-initiated trial, discount fee, all that, and so maybe just visit them and see what they're capable of and what are actual, like the processes that are involved, and what are the actual like discounted budget. Once we have that information, I think we'll be able to talk to Whipping what we want in detail.
Okay.
Yeah, let's do that. I feel like we need to, because before it was more like my fellow doing all this work,
Mhm.
and that saved a lot of budget. Whipping Lu used her laboratory, so that saved a lot of budget. But now we feel like we're paying for everything, so we feel like if we're paying for everything, we need to know what we're exactly paying for.
Right.
Let's do that. So let's figure out this before we do the final budgeting.
Okay.
Okay, that you brought it up. Okay.
Okay. Yeah. So I'll reach out to PathCore and see what they do, what they're capable of, and we'll go from there.
Yeah.
Okay. That's all the updates I have for now.
And
all
what
the
are
questions.
the meetings today?
So you have one at 2:30 with Bertis. So this is one of the newer companies from Korea that you wanted to meet up with.
Okay.
So we have an hour session with them. We have Natera from 3:30 to 4.
And then from 4, it used to be what?
On OncoSite with Dr. Huiping Liu.
Oncocyte, okay. So I just thought about one option is on my way, I feel like I can still use Zoom to listen and still without, so if because it's going to be hard and I can
Mhm.
tell them I'm like in transit, like, maybe we can still make that happen. How
Okay.
about you propose that Dr. Che is still willing to do it, but he's probably going to be on the move, but he can still join and talk and discuss or something.
Sure.
Yeah,
Okay.
let's see. I mean, we just canceled it, so maybe we can still make it happen. So it's
Okay.
4 to 5 or 4 to 4:30?
It's a 30-minute slot.
Yeah, I can still talk to them while I'm driving. It's okay.
Okay.
I don't need
So
a graph or anything for that meeting, so.
right. So if we're doing this, even for future occasions, are you available up to like 4:30 or 5?
4:30 or 4:30. And these can be meetings where I don't need to look at the screen. If I can just discuss, it's okay.
Uh-huh. Okay. So I'll see if we can keep that 4 o'clock meeting for today then.
Yeah, because it's so hard to reschedule and
Yeah.
yeah.
Okay.
Okay, so for both meetings,
Mhm.
I think you and Dr. Chisang can come and listen and join.
Yeah.
Okay. Okay, anything else?
No, that's it from me.
Okay, I will stop recording.